Hello and welcome to Digest This, where we focus on day-to-day clinical issues in gastroenterology. I'm Elaine Robertson, a gastro trainee in the west of Scotland. Today we're discussing autoimmune hepatitis, and I am delighted to welcome Dr Andrew Bathgate, a consultant hepatologist here at the Royal Infirmary of Edinburgh. Welcome Dr Bathgate, and thank you for taking the time to join us today.
No problem.
So autoimmune hepatitis is a chronic inflammatory condition affecting the liver. How common is it and who's most at risk?
Well, it is a condition that affects all ethnicities and all ages. So I think one of the common perceptions is that it only affects younger people. But I've got patients who presented in their 80s. It's true to say that the two peaks are in teenage years and probably 45 to 60. Prevalence probably about 30 per 100,000 in Western Europe, does vary throughout the world. Incidence about 1 per 100,000, so 5 a year, 6 a year in Edinburgh, slightly more in Glasgow.
And how does it present? When should we suspect the diagnosis?
So in terms of liver disease, you get the whole spectrum. You can get acute hepatitis presenting with jaundice and people feeling unwell. That's probably about a quarter, according to the literature. 2/3 more insidious, just abnormal LFTs, followed up by a liver screen pickup, autoantibodies or other pointers that might point you in that direction. And there are the occasional ones where they present with decompensated liver disease. They have cirrhosis and decompensation at time of presentation, so the whole spectrum.
And making the diagnosis isn't always straightforward. Can you talk us through it?
So, there are lots of different factors, I think, in making the diagnosis. They've tried to, the International Autoimmune Hepatitis Group tried to nail it down by going through various parameters and making a score. That became quite cumbersome, I think, but the simplified autoimmune hepatitis diagnostic criteria, I think, is much more workable, and that is based upon autoantibodies, IgG, liver biopsy, and the absence of viral hepatitis. Obviously, from the liver enzyme point of view, ALT is usually the principal enzyme abnormality. So high ALT, autoantibodies, IgG. If the autoantibodies are positive, particularly smooth muscle antibody in our setting, anti-nuclear antibody, then I would proceed to liver biopsy in these individuals, particularly if the IgG is elevated.
Do you do liver biopsy in everybody?
It's one of the few conditions where I think liver biopsy is still indicated. Yeah, I mean, obviously you can get diagnostic information as well as staging information, and as most, if not all, of the diagnostic criteria that exist out there include liver biopsy, I think liver biopsy is still an essential part of making the diagnosis. Yeah.
Do you think there's value in looking at the autoantibody profile and classifying it according to that?
Possibly. Type 1 autoimmune hepatitis is anti-smooth muscle antibody positive, ANA positive, and that's by far and away the commonest, and certainly in my practice and in the UK. The anti-LKM, I've only had 1 or 2 patients in the past 20 years who've been LKM positive, tend to be younger. But the literature would suggest that the more southerly you go in Europe, the more common that is. And the anti-LSA or liver-soluble antigen, sometimes called type 3, I've only ever seen 1 patient with that. They tend to respond in the same way to treatment, although there is some evidence that the LKM1 or type 2 respond less well in the longer term.
Are there important things that we need to rule out?
Well, false positive autoantibodies are not uncommon, particularly in non-alcoholic fatty liver disease. And certainly my approach to that has been if the IgG is normal, if they have a typical non-alcoholic fatty liver disease phenotype and there's fat on the ultrasound, I certainly wouldn't rush to biopsy all of these individuals, and tend to go really with the age and height of ALT. If the ALT was, say, 200 in those individuals, that would certainly make me more likely to biopsy them.
What about the differential diagnosis? Because in the scoring system, there are some things that get negative points.
Yeah. Well, that's in the big scoring system, and the simplified one is really just the absence of viral hepatitis. I think in the big one there's things like antimitochondrial antibody and other autoantibodies. Drugs, I suppose, is a bit of difficulty because you can get truly drug-induced autoimmune hepatitis that behaves like true blue autoimmune hepatitis. Minocycline was the original one that caused a lot of that consternation originally. That's very little used these days, and the one that we've seen most recently over the past couple of years has been nitrofurantoin, which has come back into vogue in terms of treatment for urinary tract infections, and we've certainly seen one or two of them. Obviously, that could be a drug-induced liver injury where you stop the drug, the disease goes away, but they can behave very much like autoimmune hepatitis once you've stopped the drug, and they do need treatment as you would for a normal autoimmune hepatitis patient.
So you talked about the serology in terms of making the diagnosis, and you mentioned liver biopsy. What features do we see on liver biopsy?
So the typical features, mononuclear cell infiltrate around the portal tract, spreading out into the lobular interface, and hepatitis, as it's called now, used to be piecemeal necrosis. And then obviously the more severe the injury, that extends across the liver lobule, linking them up. So you get bridging necrosis, confluent necrosis, and all of these, the more severe it is, the more necrosis there is. And obviously occasionally we would see it to the point where you get fulminant or acute liver failure, and often that's a serious business.
And then, having made the diagnosis, having done all your tests, how do you decide who to treat?
Treat most people, if not all. There'll be the occasional patient where the ALT is normal. By the time you see them back in clinic, that becomes a bit more of a challenge, because it'd be difficult to monitor disease response in that setting. But on the whole, I would encourage most people to get treatment. There are the occasional patients who their ALT bobs between 50 and 100 who don't want to take treatment, and you feel comfortable enough with that because the literature would support you in that. It does seem to be the more symptomatic and severe that end up with significant problems. But again, the disease can progress fairly insidiously, so I would be keen to treat most patients. Yeah.
Okay, and how would you treat them?
Steroids, initially. It's interesting that the guidelines as they exist suggest fairly big doses of steroids. An interesting paper earlier in the year looked at what people actually do, the so-called experts who are on the International Autoimmune Hepatitis group, and it's very variable amongst the experts. They certainly don't adhere to the guidelines, and I would tend to start with 40 milligrams of prednisolone rather than 60, as is recommended. And personally, I start treatment with steroids alone to see if they have a response to steroids, and then add in azathioprine 2 to 4 weeks later once you've seen a response to the steroids. There is some literature, only one study, that would suggest that azathioprine and prednisolone starting together might be of benefit, but I think that most people still start just with corticosteroids and then add in azathioprine after a couple of weeks.
So can you talk us through the regime that you use?
So say a typical bilirubin, maybe 60, 70, ALT 400-500. I was thinking of the most recent person, couple of weeks ago. So 40 milligrams prednisolone. The ALT usually responds very quickly, as does bilirubin. And so once the ALT is down to about 100, I would add in azathioprine. I think the benefit of knowing that the steroid responsiveness is good, and also gets the possibility, although it's small, of azathioprine hepatotoxicity out of the picture if you know what you're dealing with when you start your azathioprine.
And how do you wean the steroids?
I suppose usually, if everything's going well, I go 40 milligrams to 30 milligrams after a couple of weeks, and then 20 milligrams after another couple of weeks, and then by 5 milligrams every 4 weeks down to 5. And there's one paper which suggests that staying on 5 milligrams of prednisolone with your azathioprine for 9 to 12 months is of added benefit. And on the whole, that's what I tend to do. Keep them on low-dose prednisolone for a good number of months, and azathioprine, usually 75 milligrams a day.
Is there a role for budesonide?
There's a study which shows it's of benefit and works.
Yeah.
The paper I was alluding to earlier is interesting that none of the so-called experts use it. First line. I have used it and do use it, usually in younger people who are not keen on taking steroids. Yeah. So I think there is a role. Clearly, if you have cirrhosis and portal hypertension because it's first-pass metabolism, it might not be of any benefit in that setting given portal flow.
Yeah, and that's something actually I only found out quite recently. I'm not sure that's really widely known. What if things don't go to plan, either because of drug side effects or because things don't settle as you would like? Yeah,
so I mean, azathioprine, as you know, isn't tolerated by everybody. Probably 10-15% don't tolerate it. And so the alternatives are mycophenolate mofetil, MMF. We use that a lot in transplantation, so we're reasonably comfortable using that as an alternative in people who don't tolerate azathioprine. I'm not convinced that there's a huge amount of evidence which suggests that it's better than azathioprine in terms of response. So I wouldn't use it in people who don't respond to azathioprine, but would use it in people who are intolerant of it. 6-mercaptopurine have used occasionally, and there's some evidence for it, but obviously people who are intolerant of azathioprine often are intolerant of 6-mercaptopurine. And then when you're talking of treatment non-response, you're needing added treatment because azathioprine and prednisolone aren't enough, or because every time you wean down the prednisolone, the ALT jumps up. More recently, I've been using Advagraph for that, which is a once-daily tacrolimus. There is another once-daily tacrolimus, so any once-daily tacrolimus is obviously easier for the patient to take. Some evidence for cyclosporin, and I think in our experience, certainly in the transplant world, tacrolimus seems to be better tolerated than cyclosporin, so we would use that. Find it quite helpful.
And are you monitoring response serologically?
By that, do you mean autoantibodies?
I think that what you're saying is you're doing ALT and IgG to monitor response.
So we measure ALT, obviously, and one of the big issues is what's a normal ALT.
That's a whole other conversation, isn't it?
Absolutely. And so I think the evidence that's out there would suggest that if you're treating, you get your ALT down low, and then if it begins to go up, you should always be trying, if you can, to get it back to the lowest it's been, because that would be what the evidence would suggest. The lower your ALT in the longer term, probably the less likelihood of progression. Yeah.
And how long do you continue your initial treatment?
So steroids, as I said, probably for 9 months to 12 months, and then maintain on azathioprine.
Yeah.
The evidence would suggest that trying to stop azathioprine will relapse will occur 50% in the first year. By the time you're out to 2 or 3 years, you're looking at 90%-ish. So I tend not to stop treatment unless patients very keen to try stopping it. Again, the evidence and the guidelines would suggest if you are considering stopping it, another liver biopsy to show histological remission is required, and that often puts people off as well as myself. So I tend to keep people on long term unless they stop themselves or they're very keen to stop.
And is there a role for FibroScan or repeat liver biopsy in follow-up?
Not much data on FibroScan at all. The data that is coming through, I think there was one earlier this year in Journal of Hepatology, which suggested that once you've got the inflammation under control, because as you know, inflammation itself puts the liver stiffness up. So I think it's 6 months after starting treatment, it looks like you're going to get a reasonable FibroScan value in terms of correlation with fibrosis. And the cutoff in that study, I think it was about 16 or something like that in terms of cirrhosis. So you'd have to think that in the longer term, as more literature comes out, as it has done in PBC, I think it will be of benefit, in terms of fibrosis progression, particularly if you can keep the ALT under control. I suspect, in a few years' time we'll have FibroScans either annually or every 2 years that will tell us something helpful, yeah.
Any role for liver biopsy?
Yeah, it's difficult. So I think because the population now is bigger, by that I mean their BMI is bigger,
yeah.
Non-alcoholic fatty liver disease and ALT rise related to that comes into play quite a bit. And so I think liver biopsy I have used for people on treatment where I've just not been sure if the ALT is related to a relapse of their condition or whether they've actually got fatty liver in combination. Yep. So I do think there is a role for liver biopsy while on treatment, and I think that role is really to confirm that the ALT you're seeing is related to active disease, which will obviously change your management. Yep. I think liver biopsy for assessment of progression, unless you had other things to go, and I'm not convinced I'd be rushing to do them.
Now let me take you back to your patient who has decided they want to stop treatment and you're monitoring them. They have obviously a high risk of relapse. If they do relapse, how do you manage that?
So prednisolone again is what I would use. Now, because you're monitoring them, the ALT tends not to be at the same sort of level as you're starting initially. So I tend not to go in with the same 40 milligrams. I tend to go 30 or 20 depending on how high the ALT is. But then it's the same again. So gradually wean the steroids and convince them that maybe stopping things in the future is not a sensible thing to do. Yeah.
And are there any other aspects of management of AIH that we should be aware of?
I suppose, any treatment schedule that includes steroids, you've got to be aware of bone mineral density, so DEXA scans or assessment of bone fragility is something that you need to keep in mind. The other thing that often comes up when you're dealing with younger patients is pregnancy. Azathioprine, there's quite good literature, as I'm sure you're aware, from the inflammatory bowel disease cohorts that it's quite safe in pregnancy. We have quite a lot patients in transplantation where we continue on the medicines, and personally if they're on azathioprine I encourage them to stay on azathioprine. MMF is a no-no in pregnancy, so if they're on MMF you need to know if they're thinking about becoming pregnant and choose an alternative drug. Advigraph or tacrolimus is certainly something that is safer, and so if they had a problem in the past on azathioprine, switch them to a once daily tacrolimus.
Fantastic. Well, I'll leave you with a last question, which is there anything that you want to leave us with? Any key messages?
I mean, autoimmune hepatitis is a treatable condition, and it's an important diagnosis not to miss. I suppose the risk for me, and I suppose for all of us, is that we become slightly complacent in our diagnosis of non-alcoholic fatty liver disease as a cause of all abnormal ALTs. So I think keep in mind IgG is a helpful thing to do in these patients. And if the IgG is elevated and they've got positive autoantibodies, even if they have the kind of typical NAFL phenotype, I still think liver biopsy in these individuals is helpful. And we've certainly picked up 2 or 3 that have taken us by surprise as being true blue autoimmunes.
Fantastic. Well, all that's left is for me to thank you for a fantastic update in a really important topic. And thank you for joining us for Digest This.